Welcome to Grand Round Session and to our review of adult T-cell leukemia/lymphoma in the new classification era. We will explore the updated WHO-5 criteria and the critical shift toward molecular diagnostic precision. This is a paradigm shift moving from simple morphology to tiered criteria and new molecular gold standards. We must now navigate extensive morphological mimics and divergent genetic landscapes driven by geography. ATLL is an HTLV1-driven malignancy endemic to regions like Japan and the Caribbean, often acquired early in life. Clinically, we still use the Shimoyama classification to distinguish between long-term indolent survivors and aggressive acute cases. WHO-5 introduces a pragmatic tiered system. Essential criteria rely on morphology and serology for global accessibility. However, the, quote, desirable gold standard now requires proving monoclonal integration to rule out coincidental lymphoma in carriers. Historically, we relied on southern blot, but it fails with FFPE tissues and low tumor content. We now utilize a dual-target approach combining HBZ-ISH for spatial context and TAX-PCR for high sensitivity. This algorithm replaces southern blot entirely for tissue diagnosis. It starts with HBZ-ISH and, if results are equivocal, moves to quantitative TAX-PCR to confirm the tumor population. Morphologically, the pleomorphic variant is most common, but clinicians must watch for the anaplastic variant. These cells can mimic ALCL with horseshoe-shaped nuclei and strong CD30 positivity, creating a diagnostic pitfall. ATLL is the, quote, imitator, often confused with benign dermatopathic reactions, or angioimmunoblastic T-cell lymphoma, AITL. The key clue for AITL-like cases is that ATLL lacks the expanded follicular dendritic cell meshworks seen in true AITL. Hodgkin-like variant. The Hodgkin-like spectrum is complex, presenting as either infected tumor cells surrounding uninfected Hodgkin cells or genuine hybrid mimicry. We must distinguish these from true classic Hodgkin lymphoma simply occurring coincidentally in a carrier. Typical immunophenotype. The typical profile is CD3/CD4 positive, often with a silent phenotype that lacks CD7 and T-cell receptors. Crucially, identifying CCR4 positivity is now mandatory for eligibility for mogamulizumab therapy. Atypical phenotypes. Over 10% of cases show a T follicular helper phenotype with markers like PD1 and CXCL13, mimicking other nodal lymphomas. Because of this overlap, viral testing is mandatory for any TFH-positive case found in endemic areas. Genetics and aggression. Genetic drivers vary by aggressiveness, with mutations in PLCG1 and PRKCB driving acute types. Interestingly, we see a STAT3 paradox, where mutations are actually more common in indolent forms than in aggressive ones. Geographic heterogeneity. Geography dictates genetics. Japanese cases linked to the TAX-B viral strain show RHOA and GATA3 mutations. In contrast, Western cases with the TAX-A strain are driven by epigenetic regulators like TET2 and EP300. Epigenetically, EZH2 overexpression leads to global hypermethylation and gene silencing. This mechanism provides the rationale for targeting the PRC2 complex with new inhibitors like valemetostat. In conclusion, ATLL is a single etiology with massive morphological and genetic diversity. Accurate diagnosis now demands integrating morphology, phenotype, and molecular quantification to guide precision therapy. Hope you enjoyed the Grand Round session. Happy learning!